All right, now we're going to talk a little bit about the outcomes with different EAS types of devices. We'll look at some longitudinal outcomes with hearing preservation, and we'll also talk a little bit about some speech perception outcomes. So first we'll talk about the residual hearing. This is a slide, you'll notice this is dBHL along the vertical axis, and then we have time across the horizontal axis. 0 is pre-op, 0A is activation, and then these are in months over time. So 60 is 5 years or 60 months. All these different lines represent different types of electrodes that we have used at the University of Iowa to try to preserve residual hearing. You'll notice that there is an N of number of patients that have been implanted, and you can look at that over time. So for example, for this blue squared line that goes across time, those are our S8 patients. There are 24 of them, and they had on average an 83% preservation of residual hearing. And again, we're using the classification of functional residual hearing. So 83% of the patients on this line graph across time is using the acoustic component. They're able to functionally utilize the low frequency residual hearing. So when we look at these across time, these are all shorter electrode devices. So the L24, the S12, SRW, S8, and Flex 2024 are devices that are shorter than our standard electrode devices. The devices that are circled are standard electrode devices, so they're a little bit longer. And you can see here that 54% are using acoustic electric hearing with this purple bar. 67% are using electrical acoustic hearing with the 624. The Slim J, which is an advanced bionics electrode, is this red bar across here. We've had really good hearing preservation with that electrode. Whereas these devices here that are in the 50s percentage, upper 60s, and even the L24, we look at those over time, and we become a little bit more concerned because, there's essentially a 50-60% chance that they're going to have hearing preservation that we're going to be able to preserve, but there's also a 40 or 50% chance that they're not. And so we're very upfront with the patients when it comes to using the standard electrode devices and making sure that they understand that there is a 50 or 60% chance that we're going to be able to preserve it. But again, going back to that counseling, we really want to make sure that the patient knows that if they do lose hearing, we have a backup plan for them. And that backup plan can be implemented at any time during their post-operative appointments. I think that it does benefit the patient if they start out with acoustic and electric, and because there's no way for us at this point to be able to tell where that patient's going to land. Are they going to land in the hearing preservation, or are they going to land in the functional hearing category? But we feel like it's worthwhile, if the patient is an appropriate candidate for EAS, that if we preserve it, that we try to utilize it as long as we possibly can. Of course, there's a lot of research going on right now to try to better understand what the cause is behind the loss of residual hearing. We think that there's probably some physiologic response that happens in the inner ear. It may be caused by damage from the electrode. We'll talk about in the live session some different things that we're utilizing during the surgical procedure to try to minimize an anatomical damage to the inner ear. But it's really, we're trying to have a better understanding of what the cause is, so then we can look at ways to remediate that and be able to preserve residual hearing over time in more patients. There are a lot of patients out there that have residual hearing that don't want to move towards a cochlear implant because they're afraid that they're going to lose that residual hearing. In almost all cases that we have patients who move forward with a cochlear implant, we try to preserve it. But if we don't preserve it, they almost always do better with the cochlear implant than they did with their hearing aids preoperatively. But there is reluctance out there, and it's understandable. I can understand that perspective from the patient, but I think it is important to help the patient understand that where their speech understanding is right now with their hearing aids, that we will try to preserve residual hearing to improve that speech understanding. But even if we don't, the electrical hearing alone, we feel comfortable in that would be able to benefit from the electrical hearing over their hearing aids. So it's important to point out those things to the patient to help them feel comfortable moving forward. Because from a patient perspective, that unknown or feeling like I'm going to lose what I currently have right now is a scary thing. We're going to talk a little bit about preservation of residual hearing in borderline cases. So these are patients who we looked at, again, the 125, 250, and 500 hertz. And you can see these are borderline cases. Some of them have preoperative residual hearing at 125 and 250, but then they drop out at 500. Some patients, we tried to preserve residual hearing at 125 and 250, but they were really borderline there. And so even at 500, they are barely a candidate for EAS. But this is some early work to try to understand, again, going back to where is that border for a patient that we want to consider a good EAS candidate versus a patient who we think we want to just adopt a more of a standard length cochlear implant and have them utilize that bimodal hearing. So if we look at these thresholds, here's their pre-op, and here's what happens to these patients post-op. Some of the patients that had good low frequency hearing at 125 and 250, again, they're 500 hertz. We weren't able to preserve, but we were still able to utilize 125 and 250. They're the patients that started a little bit better. So they had a little bit more hearing at that 125 and 250 preoperatively. The patients that had poorer hearing, you can see where they started out poor. They lost that 15 to 25 dB hearing just due to the surgical procedure. And now we're sitting here at more of a non-functional standard electrode patient. And so again, going back to supporting, when do you want to talk about preservation of residual hearing, and when is it appropriate just to say we're going to put a standard electrode in and not plan to amplify and provide EAS type stimulation. Likewise, here are a group of patients who have really good preoperative residual hearing. They're kind of all above. Some of them have no 500 hertz, but for the most part, 125 and 250 looks really strong. But these patients are all 65 years and older. And so what happens to them after they're implanted? And again, this goes back to we really need to consider age here if we want to preserve residual hearing. So some of those patients, again, now they drop down here and they've lost some of that residual hearing. Some of these patients up here that had really good hearing preoperatively were still able to preserve it and move forward. But again, if you have a borderline case that they're borderline age and borderline thresholds for already being kind of at that borderline for they're already at that 60 dB or close to it, preoperatively at 125, 250, it may be that, again, that in combination with age would lead you to maybe just move forward with a standard electrode and not try to preserve the residual hearing or amplify it if they have a little bit of it. Some of these patients up here, if they drop off precipitatively after 500 hertz, but they have good low frequency hearing, and they are a little bit older, I still think it's worthwhile to talk to them about trying to preserve that residual hearing and amplify it if we can. Because it makes sense to do that. If these patients have normal low frequency hearing or very mild, I think the chance of them preserving and being able to score better or perceive speech understanding better with a cochlear implant, it's going to be worthwhile moving them in that direction. But again, counseling them that you have a backup plan. If they lose that low frequency hearing, you hope that they don't, we have a backup plan for you. But again, this is just giving you some evidence, some information to put in your back pocket and think about when these patients are coming through. Where are their hearing thresholds starting in these low pitches? Where do you think it's going to end? So if they're borderline with thresholds, are they borderline for age? Those are things you just want to kind of think about and counsel through it with the patient appropriately. So let's look at speech perception outcomes. Again, we're going to really talk about some of those borderline patients. Let's talk about the borderline audiometric patients. So they were just right along that 55, 60 dB thresholds preoperatively. And let's talk about what happened to them after they were implanted. Some of them may have lost their hearing, and some of them maybe just have a little bit at 125 and 250. But let's see how their outcomes are. So these are CNC word scores. Again, we want to collect the same scores pre and the same scores post-operatively. This is in the combined mode. So this is with them wearing their acoustic electric on one ear and their hearing aid on the opposite ear. The purple are their pre-op scores. So this is with bilateral hearing aids preoperatively. You can see some of these patients with bilateral hearing aids preoperatively are amazing users. But some are pretty poor users, even with bilateral hearing aids. The orange shows their post-op hearing. Okay, so here's what they're scoring post-operatively. So you see a patient with bilateral hearing aids scoring way under 10%, but look at that benefit that they're getting with their cochlear implant. When we move forward, some of these bars change to blue, some change to red. The patients with blue are the borderline cases. So before we implanted them, they were just barely borderline for their thresholds. They preserved that borderline thresholds at 125 and 250. The patients with the red are the patients that lost their hearing. So they were borderline and they ended up losing their residual hearing. The patients in the orange are patients that we were able to preserve all of their residual hearing and use 125 through 500 hertz. So the patients that were blue ended up, we just amplifying 125 and 250. The patients in orange are the patients that were able to amplify and utilize 125 through 500. And the patients that are in red are those that lost all of their residual hearing and are only using electrical in that ear. All of these, again, are combined with their contralateral hearing aid score. So you can see even patients that are borderline are still able to benefit significantly from that acoustic hearing. Even this patient here, preoperatively, they were scoring a little over 20%. They lost all their residual hearing, but they're still able to get 80% in combination with that hearing aid on the opposite ear, upwards of 85%. That's really good. This patient here lost all of their hearing and their score actually did get poor. So that's a patient that we would want to follow up with and determine, look at their electrode type, what type of electrode were they implanted with. If it's a short electrode, maybe you would want to consider explantation and reimplantation with a longer electrode. Or you want to look at the programming and make sure that their contralateral hearing aid is appropriately fit. And maybe that's a patient again that's look back at their etiology their duration of hearing loss, their duration of high frequency hearing loss, to try to better understand why that patient actually got worse. Because you'll notice that's not very common. You know, with all 40 of these patients, we have 3 patients that got poorer post-operatively. And so it's not very common, even if they were borderline or not, that these patients all succeeded and got better with their cochlear implant. These are just some CNC words that I felt like was a nice comparison. So we have 43 acoustic and electric hearing patients here. We have 7 acoustic and electric patients that we tried to preserve hearing, but they ended up losing their residual hearing on that implanted ear. We have some patients here that are standard bimodal, so they didn't have very good residual hearing in their implanted ear before they were implanted, and we didn't plan on trying to preserve their residual hearing, and so we have 28 of those bimodal patients versus 7 patients who had pretty good residual hearing and they lost it. So presumably these patients here have better nerve survival in their ear because they had good residual hearing before. These patients here were poor before, had poor hearing before they were implanted, and they're being provided bimodal stimulation. These are patients that have standard bilateral hearing aids. So they had poor hearing before they were implanted. They got implanted with standard bilateral cochlear implants. And then these are patients that have unilateral cochlear implants, but they do not have hearing in the contralateral ear. So they are not single-sided deafened patients. They're simply patients who don't have good hearing on either ear preoperatively. We give them one cochlear implant. They're not using a hearing aid on the other ear. So that gives you a little bit of history about this graph. When we look at our unilateral users, they're doing significantly poorer than any of these other groups. So all of these other groups are patients that are utilizing hearing on both ears. They're utilizing a contralateral hearing aid on the implanted ear. And so right there out of the gate, this tells us that having hearing on both ears is really beneficial. Wow, something we kind of already knew, but I think when you look at it this way, it's important to point that out. Then when we look at these patients here, these have acoustic and electric hearing, and these have no acoustic hearing, and they're, the EAS patients are significantly better at performance than the bilateral no acoustic hearing patients. Now let's look at some of these over time with AZ biosentences in a +5 noise. Again, speech and noise are coming from the front. This is a very difficult listening situation for these patients, but I think this is really where we see that acoustic component pop out and show that it's really beneficial to these patients. So let's go through these different groups. We have our L24 patients, so that's a hearing preservation electrode. This is their green bar over time. There's 55 of those patients in this line. We have L24 patients that have lost their acoustic hearing on their implanted ear, and now they're functioning bimodally here. So they have acoustic hearing on one ear and all electric on the other. So that's this bar here. Then we have a group of standard bimodal users. So these are acoustic on one ear. They had poor hearing before they were implanted. We never tried to preserve it. So they've always been bimodal. That's their bar here. We have a group of S12 users. That's this bar up here. Those are patients that have a 10 millimeter electrode and 10 electrodes. So that's different than the L24 where they have a 16 millimeter electrode with 24 electrodes. So this is a quite short electrode, but there's 13 of these patients, and you can see they started out a little bit better. That's why they were implanted with the S12. They had even better hearing than some of these L24 users. preoperatively, and so we wanted to put in a shorter electrode because they had more residual hearing that we wanted to try to preserve. So we put in an electrode that was shorter, that stayed away from that apical region, didn't go into the cochlea as far. These SRW patients are very similar to our S12 patients. And again, there's only 4 of them in this graph, but it's again a very short electrode. It's 12 millimeters in length rather than the 10 like the S12, but it's still a very short type of electrode. And again, we want to utilize that electrode in patients with pretty significant amounts of residual hearing preoperatively. So these patients, because they had more residual hearing, started with speech perception that was a little bit better. They still were under the 60%, but they weren't near as bad as the group of patients that started here. You can tell by this, the patients that have residual hearing we were able to preserve all of their hearing postoperatively, and you can see where that residual hearing is really beneficial to these patients when they're listening to AZ bios and backgrounds of noise. These patients went from about a 52% up to almost 90% in a background of AZ bio sentences and +5 noise. Likewise, the S12 patients went from about 42% to an average of about 70% on AZ bio sentences and a +5 noise. Again, the majority of these patients, I think 10 out of 13 patients were able to preserve their residual hearing. So about 80% of the patients had preservation of residual hearing. And so their outcomes look very good as well in backgrounds of noise. When we look at the hybrid bimodal patients that lost their residual hearing on their implanted ear compared to our standard bimodal patients, they're all scoring pretty similarly. The L24s are a little bit better. They have residual hearing on that implanted ear. Their preservation of those 55, that's showing all of the patients that have preservation. And again, 21 lost their hearing, but the ones that preserved their hearing are doing a little bit better than those that don't have acoustic ipsilateral acoustic hearing. When we look at that same graph, but now I'm going to take the L24 patients and I broke them down into patients who are older than 65 and which is this dotted line right here. These are older than 65. And then these are the L24 patients that are younger than 65. And you can see a pretty significant difference in even though all of these patients have preservation of residual hearing, the patients that are older just do a little bit poorer on this AZ biosentence test and a +5 noise. Those that are younger do a little bit better, and that's again evidence that we really want to take into consideration age when we look at stimulating these patients acoustic and electrically, because for all intents and purposes, the patients that are a little bit older are performing about as good as the patients that are bimodal. And so maybe with those patients that are a little bit older, just going with a standard electrode, not trying to preserve, not trying to stimulate acoustic electric hearing may be what you want to think about. All of it's going to be dependent on that patient, what their goals are, and how much residual hearing was actually preserved for them.